Good afternoon, everyone. This is Sir Franz, and this time I'll be giving you the last part of our lectures on neuropharmacology, and this time we'll be discussing diseases that affect the mind and drugs used in these psychiatric diseases. We'll only be discussing three of um, the major and common psychiatric diseases. Please take note that there are a variety of psychiatric disorders that are beyond our scope for this discussion. So this afternoon we'll be discussing depression, anxiety, and psychosis. And my goal is just to introduce the disorder to you, and so that you can read in greater detail if you are interested to learn more. And after we have discussed briefly the disorder, then we will proceed with how drugs are used to treat these disorders. So first would be depression. In depression. So here, to be specific, this is major depressive disorder, a form of depression. And there are many other forms of depression. So the findings that you will see here are for major depressive disorder. The findings that we will see can be divided into based on the nature of the findings. So we have behavioral features, emotional features, and cognitive features. So behavioral features include psychomotor retardation. That means that the thinking together with the movement of the person slows down. There is agitation, but this is not seen every time. There is an altered facial expression, so you will see them frowning almost all of the time. There is self-neglect, and if you will read further, this is because of decrease in the function of a particular region of the cortex. And there is social withdrawal. They will try not to interact or mingle with their peers or their loved ones. Included in the emotional features are low mood, and this low mood is further described based on its quality. There is depth, which means that the low mood is extreme in nature. And there is pervasiveness, which means that this low mood incorporates into all aspects of the person's daily life. This low mood can also be described in terms of quantity or duration. So this low mood specifically lasts for greater than 2 weeks. Okay, if it lasts only for less than 2 weeks, then it is less likely major depressive disorder. However, if it is very severe or extreme, it can still be qualified as depression. Another emotional feature is tearfulness, loss of interest in normally pleasurable activities, and there is a medical term for that which is beyond our discussion. Anhedonia is the lack of perception of pleasure. So that means that those that are normally pleasurable for a person, such as eating, such as having sex, exercise, these become less pleasurable in a person with depression. There is loss of reactivity to external events. There is irritability and there is anxiety. So what I'd like to highlight here is that some findings of depression overlap with the findings of anxiety. And more commonly, those with depression will have a comorbid anxiety. So that is also the other way around. But there are also persons who have isolated depression and isolated anxiety. Another group of findings would be cognitive features. What happens in the thought processes of these persons or these patients? There is slowing of the speed of thought. There is reduced speed and latency of speech, which means that the volume of words that they produce are decreased. So the amount of words that they say are less compared to a normal person. There is reduced volume of speech. There is reduced tonal modulation, which means the natural variation in the rise and fall of the tone when you are talking, that is reduced in a person with depression. So you will usually find them in a monotonous tone. Okay, there's impairment in concentration, memory disturbance, and this is very important because um, we have to differentiate if these patients have dementia or if they have depression. So we need to check into this in detail. And they have negative views of the self, the world, and the future. So that is pessimism. Biological features. So this is what I'd like to emphasize. For all of the psychiatric disorders that we will be talking about this afternoon, you will see that they have biological features. And that just shows that these are real illnesses. So I'd like to emphasize that psychiatric disorders are real medical illnesses. And they are just not a um, they're just not a bushel of fiction. No, hindi lang siya iniisip lang. So included in the biological features in depression would be a diurnal variation of mood, which means that when the sun is up, uh, the findings in depression are um, minimal in extent, or they may even not show. And when it comes to nighttime, those or when the sun sets, that's the time that these findings will show up. There is sleep disturbance, so there may be somnolence, which means that these patients will sleep longer and more often than usual, or there may be insomnia, which means that these patients may have a difficult time sleeping, going into sleep and staying in sleep for a long time. There is loss of appetite, which is common because, as we've discussed a while ago, they have decreased uh, sensation of pleasure with normally pleasurable things such as eating and intake of food. And this results to weight loss. But there is an atypical presentation of weight gain. So commonly they will experience weight loss, but some of them will experience weight gain. There is loss of libido, there is fatigue, constipation, and because of these disturbances in sleep, in intake, in the levels of stress, in females, this affects the hypothalamic pituitary gonadal axis so that they will present with amenorrhea or lack of menstruation. Explain depression. So there are a lot of theories. No? These can be biological, um, psychological, and social. But our focus here in this pharmacology lecture would be the biological theories. So that is because our treatments directly address these theories. So for depression, it's the monoamine deficiency theory. So monoamine refers to the structure of these neurotransmitters. You can also say catecholamine deficiency theory. So that would mean that involved here are the catecholamines, norepinephrine, and serotonin. But there is a minor involvement of dopamine. So the most important neurotransmitter that is deficient in persons with depression is serotonin. And what are our evidences that serotonin is deficient in the brains of patients with depression? They found out that the precursor for serotonin, which is tryptophan, is reduced in its availability in the brain. Therefore, because the precursor is less in concentration in the brain, it cannot produce serotonin. There is enhanced hepatic tryptophan catabolism via the kynurenine pathway. So, tryptophan is the precursor for serotonin and it has to enter the brain. But if tryptophan, which is present in the bloodstream, is taken up by the liver and degraded by the liver, forming kynurenine, the availability of serotonin, the availability of tryptophan for conversion to serotonin in the brain would be less, as well as kynurenine causes CNS depression. Low CSF concentration of serotonin is found in suicidal patients. So that is direct evidence that in the major complication of depression, which is suicide, serotonin plays a role. If there is low serotonin, then these patients are more likely to experience depression. Next would be norepinephrine deficiency. They found out that in patients who are depressed and given antidepressants, in these patients, if the receptors for norepinephrine are downregulated, which means that the receptors in the cell surface of these neurons are not available, they are few in number, then there is an expected poor antidepressant response. The medications that you give to treat the depression will not work in these patients, or these patients will have resistance to these antidepressants. Next, activation of presynaptic adrenergic receptors on noradrenergic and serotonergic neurons are found in patients with depression. So, with this, you have to remember your lecture in autonomics, which tells us that adrenergic receptors, which are found post-synaptically, will either activate the postsynaptic neuron by binding to GS, or at the same time, in a minimal fashion, inhibit that postsynaptic neuron by binding to GI. But more often than not, presynaptically, the neuron contains an adrenergic receptor, which is most commonly alpha 2. So this alpha 2 receptor is coupled with GI, G protein subunit I, which means that when bound, these receptors will act as an auto-inhibitory mechanism, telling the presynaptic neuron that you have already released your norepinephrine it's time to slow down the release so that there is regulation. They found out that in patients with depression, these auto-inhibitory presynaptic adrenergic receptors are more functional and more frequent. Next, there is clinical response with indirect adrenergic agonists. So when we say indirect adrenergic agonists, these drugs increase the bioavailability of norepinephrine in the synapse by inhibiting their breakdown. So an example of this would be inhibitors of monoamine oxidase. They found out that in patients with depression, when you give them monoamine oxidase inhibitors, there is an improvement in the symptoms of depression. Showing the mechanisms of action and the sites of action of the common antidepressant classes that we use. So, since we know that in depression there is a relative decrease in the bioavailability and effect of norepinephrine and serotonin, the drugs that we use would also treat depression by reversing that pathophysiology. And these drugs increase the bioavailability of norepinephrine and serotonin in the synapse. So here you have two sets of synapses and two sets of presynaptic and postsynaptic neurons. So on the above synapse, and this is a noradrenergic synapse, which means that norepinephrine is the bioactive neurotransmitter in the synapse. You will see that norepinephrine is synthesized and stored in a vesicle. And when there are appropriate facilitatory signals, these norepinephrine vesicles fuse with the cell membrane and become bioavailable in the synapse. However, norepinephrine and its release can be inhibited when alpha 2 receptors are activated in the same presynaptic neuron. Remember that alpha 2 is coupled with G protein subunit I, which means that this G protein subunit I will activate a phosphatase that will inhibit adenylyl cyclase, and therefore there will be a relative decrease in CAMP. With a decrease in CAMP, the activation of protein kinase A would be less than optimal. And when protein kinase A is not active, then its phosphorylation of the vesicle will also be less. And this results to a decrease in the translocation of the vesicle and its release into the synapse. The same mechanism is afforded by serotonin, but in this time, serotonin will have to act at a specific inhibitory receptor, which is the serotonin 1D 2A receptor. Okay, so the end effect of these two would be to decrease the release of norepinephrine. Okay, so what do we want to do? Okay, as much as possible, we do not want to give these patients drugs that are agonists at these receptors, because if you do so, the norepinephrine release will decrease, and that will predispose the patient to an attack of depression, no? Or the occurrence of depression. So one of the more common sites of action would be the inhibition of the norepinephrine transporter. So the norepinephrine transporter catalyzes the reuptake of norepinephrine from the synapse back into the presynaptic neuron. So by performing the reuptake process, norepinephrine becomes unavailable in the synapse. So we want to block that so that norepinephrine becomes available in the synapse, and thus it can bind to the postsynaptic receptors. So drugs that block norepinephrine transporter and therefore block the reuptake of norepinephrine and increase the concentration of epinephrine in the synapse include the tricyclic antidepressants and the combination serotonin-norepinephrine reuptake inhibitors. The serotonin-norepinephrine reuptake inhibitors are also known as second-generation antidepressants. They're also known as atypical antidepressants. Next, we can also inhibit the process that degrades norepinephrine. So the enzyme that degrades norepinephrine is monoamine oxidase type 1, okay, or monoamine oxidase A. So when we block that, okay, the norepinephrine is not degraded, therefore it becomes more bioavailable in the synapse, and it can bind directly to its postsynaptic receptors, which are usually alpha 1 and the beta receptor. So a special properties of this, take note of this, of the tricyclic antidepressants would be its direct acting activity. So in the mechanism that we have described a while ago, the blockade of norepinephrine transporter and reuptake, that is an indirect sympathomimetic activity of tricyclic antidepressants. But the TCAs also have a direct activity on the alpha 1 receptor. And so, tricyclic antidepressants have dual mechanisms of action and are therefore have a effect profile which is wider. Okay, so the activity of norepinephrine on the alpha 1 receptor leads to an increase in intracellular calcium via the inositide pathway. So alpha 1 is coupled to GQ, and the activity of GQ would be transduced by the formation of inositol triphosphate. And this inositol triphosphate, together with the diacylglycerol, will concomitantly increase the levels of calcium intracellularly. When calcium levels have already increased, this will turn on the activity of the cell by activating protein kinase C, or causing vesicles to fuse with the cell membrane. Okay, now let's go into the synapse for serotonin. Serotonin, similarly, is synthesized in the presynaptic neuron and stored in a vesicle. This release is again facilitated by facilitatory or interneurons, no, synapsing between this synapse and a smaller synapse with the presynaptic neuron. So the release of serotonin is facilitated by those interneurons, and the action of serotonin is terminated by its reuptake. So the reuptake is catalyzed by the serotonin transporter. much like the norepinephrine transporter. And serotonin can also be degraded by monoamine oxidase type 1 or type A. So drugs that act on the serotonin transporter are similar. You have the tricyclic antidepressants, the non-selective serotonin or epinephrine reuptake inhibitors, and the selective serotonin reuptake inhibitors, or the SSRIs. The SSRIs are the traditional antidepressants, no? And they are also called first generation antidepressants. So next would be the inhibition of the release of serotonin via alpha 2 and the serotonin 1A, 1D, and serotonin 7 presynaptic receptors. So again, they are inhibitory in nature. They are auto-inhibitory receptors, which in the natural synapse would act to regulate the release. So once the release of serotonin has already occurred, these neurotransmitters, these receptors, inhibit further release so that there is no excessive release of serotonin. So please take note of this slide and this table. Examples of tricyclic antidepressants include imipramine, amitriptyline, and nortriptyline. As you recall a while ago, tricyclic antidepressants have direct adrenergic activity. And so, their use can be extended not just from treating depression, but also in other psychiatric and even physiologic disorders. So, example of that would be nocturnal enuresis. Imipramine can be used to treat abnormal nocturnal enuresis, which means that these patients wet their beds and they are older than 4 years old. Next would be amitriptyline. The special information for amitriptyline is that it colors the urine green. So that would be an important question, especially in your toxicology. So when a patient presents with green urine, you can suspect amitriptyline use or blue-green urine for amitriptyline, green to blue-green urine. Examples of selective serotonin reuptake inhibitors, which are first-generation antidepressants, are fluoxetine, sertraline, and escitalopram. So, with the safest profile in these sets of SSRIs is escitalopram. Fluoxetine and sertraline, and fluoxetine more specifically, has a black box warning because it has shown that in inappropriately dosed individuals, which means that the prescription for fluoxetine contains a less than needed dose of fluoxetine. In these individuals, suicide tendencies are increased. Next, sertraline has an unwanted side effect in some patients of inappropriate weight loss. So this is the reason why a few years back here in the country, sertraline was abused to produce weight loss. Next would be the serotonin norepinephrine reuptake inhibitors, and these are second generation antidepressants. So serotonin, norepinephrine, reuptake inhibitors block both the reuptake of these two neurotransmitters, and therefore, with the increased levels of both serotonin and norepinephrine, potentiation and synergism even can be observed. And therefore, these drugs are very potent antidepressants. So much so that if a patient has resistance to selective serotonin reuptake inhibitors, SSRIs, which are the first line agents, the psychiatrist can give serotonin norepinephrine reuptake inhibitors to treat that SSRI resistant depression. Serotonin norepinephrine reuptake inhibitors are also special because reports of studies done in Europe found out that some of these patients with depression, when treated with serotonin norepinephrine reuptake inhibitors, actually exhibit cure. So they are cured of their depression. And so if the goal of treatment would be to attempt to eradicate depression and therefore prevent its recurrence, SNRIs can be a drug of choice. Examples of SNRIs are venlafaxine, duloxetine, and milnacipran. Monoamine oxidase inhibitors include tranylcypromine, phenelzine, and isocarboxazine. So, again, these drugs increase the levels of both serotonin and norepinephrine by inhibiting their destruction in the synapse. But there is a very important drug-drug reaction here. You must never combine TCAs, SSRIs, SNRIs with a monoamine oxidase inhibitor because this will result to a syndrome that is called serotonin syndrome. So with the increase in the available levels of serotonin in the synapse by inhibiting their reuptake together with an increase in serotonin by a mechanism inhibiting its destruction, then the excessive levels of serotonin will lead to psychosis, so manifestations of psychosis, fever, increased heart rate, to a point that it is already dysrhythmic, and findings of gangrene in the digits because serotonin is a potent vasoconstrictor. So these constellations of findings are the manifestations of serotonin syndrome, which occurs when SSRIs usually are combined with monoamine oxidase inhibitors. Into anxiety. Generalized anxiety disorder. So GAD, or generalized anxiety disorder, is a specific form of anxiety, and there are many others. So what do we see in patients with GAD? There is excessive anxiety and worry. This is accompanied by motor tension or restlessness. This interferes with other aspects of a person's life, such as his work, his school, um, his or her family life, and his or her relationship with others, and in general, his or her functioning. This is chronic, lasting more than 6 months, and this is not due to a substance or other medical disorder. This is important because there are drugs that increase the levels of norepinephrine in the brain, and these drugs indirectly cause anxiety. And so when we have to find out if this person has GAD, we need to first make sure that they are not taking any drugs. Examples of these drugs would be amphetamine derivatives such as methamphetamine and ecstasy. Okay. Another important aspect of anxiety is that some medical disorders produce anxiety. A very common disorder is hyperthyroidism, where the excess thyroid hormones produced by the hyperfunctioning thyroid gland acts in the brain by increasing the number of norepinephrine receptors, and therefore functionally it will produce symptoms of anxiety. These are manifested as hypercerebrism, or inability to slow down thoughts. So that is the psychiatric manifestation of hyperthyroidism. So this must also be considered when we want to find out if this person has primary anxiety. So also in patients with GAD, there is a vicious cycle of worrying and then noticing that you are worrying and then worrying because you are worrying. So that leads to potentiation and a worsening of the worry. So that is a common process in patients with GAD. Of these anxiety disorders. So the biologic manifestations, which are the physical findings in these patients, are very readily explained by hyperactivity of the sympathetic nervous system. Okay, so these findings include tachycardia, a fast heart rate, headache, diarrhea, and tachypnea. So headache in these patients occur due to first constriction and then reflex vasodilation of the blood vessels in the meninges, which is the covering of the brain. So first, it will vasoconstrict, and then these nervous signals are overpowered by the blood vessel itself, and this leads to vasodilation. And when the meninges are, or the covering of the brain is stretched, this leads to headache. Diarrhea is due to the mixed effect of norepinephrine in the gastrointestinal tract. So when there is sympathetic stimulation of the gastrointestinal tract, secretion increases. But if there is too much release of norepinephrine into the enteric nervous system of the gastrointestinal tract, then this will lead to blood vessel constriction and later on decrease in activity of the gastrointestinal tract. So again, in the gastrointestinal tract, norepinephrine, if released in moderate amounts, will increase motility and secretion of the GIT. But in higher amounts, norepinephrine will vasoconstrict the blood vessels supplying the gastrointestinal tract, and this will lead to decreased function of the gastrointestinal tract. Okay, so some of the neurotransmitter abnormalities that we see in anxiety disorders are increased norepinephrine activity, and again, we have explained this a while ago. together with the physical findings that we have. So norepinephrine, if you look at the image in your right, is released by the locus coeruleus. So the locus coeruleus is a part of the midbrain. No? So it will give off norepinephrine into the hippocampus, which is the memory center of the brain. It will give off norepinephrine into the amygdala, which is the fear center of the brain. And so, when the locus coeruleus is hyperactive, there is increased release of norepinephrine into the amygdala, especially. And this leads to inappropriate fear, worry, and the thought findings in anxiety. There is also increased serotonin turnover in the brain. So serotonin in the brain is produced by the raphe nuclei, which is found in the brain stem. So the raphe nuclei will give off serotonin into the limbic system, which is the colored regions you will see in the photo. That's the limbic system. So there are serotonin molecules going there from the raphe nuclei. So they found out that in patients with anxiety, serotonin is avidly released by the raphe nuclei, but it is also avidly destroyed. So right there is a neurotransmitter imbalance. Lastly, patients with anxiety have decreased GABA signaling. So GABA, gamma aminobutyric acid, is a primary inhibitory neurotransmitter in the central nervous system, and it is made from glutamate. Okay, so GABA causes CNS inhibition, and in patients with anxiety, they found out that the levels of GABA are low, the production of GABA is slow, and when they give patients with anxiety disorders with the GABA antagonist flumazenil, they found out that these patients with anxiety disorders experience an acute panic attack. So that finding is evidence that GABA plays a role in anxiety. Lastly, it is not just the neurotransmitters that are abnormal, but hormones are also abnormal in patients with anxiety disorder. So there is increased cortisol release from the hypothalamic pituitary adrenal axis. And if you will recall, cortisol is the stress hormone. It allows the person to adapt to physical and emotional stress. So cortisol mobilizes the energy stores. And the end goal there is to release glucose and increase glucose in the bloodstream. So with this, you will see increased lipid metabolism and increased breakdown of protein. So those are biochemical abnormalities from high levels of cortisol. Next, cortisol creates an impairment in the immune function of the patient, which means that when cortisol is increased for a prolonged period, then there would be a decrease in immunity and a susceptibility to infection and malignancy or cancer. So the point here is that patients with the psychiatric disorder of anxiety, because they manifest with increased cortisol activity, will also suffer from the complications of prolonged and high levels of cortisol, such as hypertension, such as metabolic syndrome, okay, and more common occurrence of infections. In the treatment of anxiety, there are two steps. First, you need to um, immediately or acutely treat um, a panic attack, which is the usual presentation of patients with anxiety disorders. So there is a severe panic attack, um, and you need to first address that. Okay, so to address that, we need to perform anxiolysis, which is the acute, the fast onset relief of anxiety in the panic attack. So to do that, we utilize GABAergic drugs. Examples of GABAergic drugs are barbiturates and benzodiazepines. So barbiturates and benzodiazepines act on the chloride channel. And here in the photo, this is the chloride channel with 5 subunits, 2 of which are alpha and 2 of which are beta, and 1 gamma subunit. So barbiturates act on the alpha and beta subunit, and the barbiturates create a conformation of the chloride channel which prevents its closing, which means that the chloride channel is open for a longer period of time. Barbiturates increase the duration of chloride channel opening, whereas benzodiazepines act between the alpha and gamma subunit. And the effect of the change in conformation in the chloride channel would be an increased frequency of the opening of the chloride channel, whether it is a benzodiazepine, which increases the frequency of chloride channel opening, or a barbiturate, which increases the duration of chloride channel opening. The end effect is an increase in the levels of chloride intracellularly, and this hyperpolarizes the neurons and prevents release of neurotransmitters, which in the case of anxiety are norepinephrine and serotonin. So by decreasing the release of these neurotransmitters in the synapse, anxiety is sliced. It is acutely treated. But a second component of the treatment of anxiety disorders would be to stabilize the patient um, and prevent a recurrence of another anxiety attack, and to treat the symptoms, decrease the symptoms that we have described a while ago, excessive fear and worry, for the long term. And to do that, we utilize the same agents that handle serotonin that we use in depression. So these agents include SSRIs, and therefore SSRIs can be used to treat both depression and anxiety. Okay. In anxiety, it is used for chronic treatment to reduce the symptoms and prevent recurrence of an anxiety attack or a panic attack. Lastly, we'll be discussing psychosis. So, psychosis is a manifestation, and there are a lot of disorders that can cause psychosis. The most common um, primary psychiatric disorder manifesting as psychosis is schizophrenia. So, schizophrenia and psychosis in general manifests with delusions, which means that the patient believes something that is not true. So these thoughts are incorrect, but the patient believes them to be correct. For example, a patient who believes that he or she is the daughter of Queen Elizabeth, even if that patient lives in the Philippines and is frankly Filipino in features. So that's a delusion. Belief in these are fixed, false beliefs. Hallucinations are perceptions of entities which are not present. So there is no stimulus, but there is a perception. For example, um, hearing voices, even if there is um, no one around or near the person. So it is important to note that these voices that are heard um, does not come from inside the person, but are perceived as if it is heard from the ear. So that's an auditory hallucination. It is different when the person uh, hears, but the voices come from inside. No? The voices should be coming as if they are heard by the ear. A next finding in schizophrenia is disorganized speech. There can be derailment or incoherence. One thought is connected to another distant thought. For example, at one time, the patient is talking about a very good breakfast with coffee, and then without any pause or without any transition, talks about um, how nice um, the color purple is. So, for example, as if I'm the patient, I'll be saying, I really like coffee. That table is purple. So there is a frank uh, incoherence between the two statements. Next, there is disorganized or catatonic behavior. Um, these four, no, delusions, hallucinations, disorganized speech, and disorganized behavior, these are the positive symptoms of psychosis or schizophrenia. We also have negative symptoms of schizophrenia, and these include diminished emotional expression or avolition. So the level of functioning is markedly depressed, and this should affect the person's life, so daily life. Therefore, if these findings are in the context of not affecting a person's daily life, then this does not fit the diagnosis of schizophrenia. Uh, there must be chronic duration, so that means that the disorder lasts for greater than 6 months. And it is not due to a substance. Again, there are a lot of substances that may manifest as psychosis. And this include intake of your hallucinogens. Okay, an example of that is marijuana. That's a hallucinogen, or methamphetamine. Or this must not be due to another medical disorder. For example, in patients with systemic lupus erythematosus, if the brain is affected, then they will manifest with psychosis. So what causes schizophrenia, or what do we know about schizophrenia? There is a genetic basis to perhaps all forms of schizophrenia, which means that it runs in the family. Brothers and sisters who have schizophrenia are will predispose the other siblings to schizophrenia. So it means that if the parent has schizophrenia, there is a higher chance that his or her kid will have schizophrenia. The dopamine hypothesis states that schizophrenia is due to excess dopamine. They found out that in the brains of patients with schizophrenia, there is a relative decrease in acetylcholine and a relative increase in the levels of dopaminergic neurons. They also found out, in connection to that, that the prefrontal cortex, which is the most anterior portion of the frontal lobe, the cortex is shrunken in schizophrenic patients. And this is because in that region, acetylcholine is the most important neurotransmitter, and it is shrunken in these patients. And therefore, since the prefrontal cortex is also the seat of executive function, okay, executive function means planning, organizing, sifting through one's thought. When you have a lesion in the prefrontal cortex, as in patients with schizophrenia, they will manifest with the symptoms that we described a while ago. Okay, so this is another evidence right here that mental disorders are not just theories, no, they are real medical disorders. Again, psychiatric disorders are not just a bushel of fiction, they are real disorders because they manifest physically. No? Here in the brain of a patient with schizophrenia, the prefrontal cortex is shrunken. Serotonin is also abnormally elevated and results to both positive and negative symptoms. So a while ago, I described serotonin syndrome, where there is excess serotonin, and these patients manifest with psychosis. Anhedonia, okay, which is the lack of interest or the lack of perception of pleasure in normally pleasurable activities, can be due to degeneration of norepinephrine neurons in the norepinephrine reward circuit. So, like dopamine, norepinephrine also has its own reward circuit in the brain. When something pleasurable is experienced, norepinephrine is released in that region of the brain, which is the reward circuit. When patients with schizophrenia have their brain autopsied, okay, they found out that this norepinephrine reward circuit is degenerated. So, this explains the findings of anhedonia in patients with schizophrenia. GABAergic neurons, which help tone down the activity of the brain, no? Which are found in the hippocampus, are also degenerated in schizophrenic individuals. Thus, the flagrant positive signs and symptoms: hallucination, delusion, disorganized thought and speech, and disorganized behavior. All of this is because certain regions of the brain are not inhibited enough. And why are they not inhibited? Because GABA neurons have degenerated in schizophrenic individuals. So, this is a similar slide as to the noradrenergic and serotonergic synapse. But here you will find out how drugs act in the dopaminergic synapse. So again, dopamine is released from the vesicle, and this release and synthesis is upregulated by the levels of CAMP, which are down-regulated by dopamine 2 and dopamine 3 receptors and alpha 2 receptors, which means that when these receptors, alpha 2, dopamine 2, and dopamine 3 are activated, dopamine release will go down because first the synthesis is inhibited, and again, the release itself is inhibited. Next, dopamine, once it is released into the synapse, will act on postsynaptic receptors. So the primary postsynaptic receptor would be dopamine 1. When dopamine 1 binds dopamine, then the levels of CAMP will increase and the cell will become activated. Okay? In dopamine 2 postsynaptic receptor, this is coupled to GQ, and therefore it will release calcium from intracellular stores in the neuron, and that calcium will then activate the cell. But remember, dopamine 2 can also occur presynaptically, where it functions as an auto-inhibitor so that no further release of dopamine occurs. Next, dopamine in the synapse is terminated in activity by its reuptake and its further destruction by MAO, MAO-B, monoamine oxidase isoform B. So technically, this is how the dopaminergic neuron functions. Let's plug in the drugs. We have drugs that block the dopamine 1 receptor. And when the dopamine 1 receptor is blocked by these agents, the typical antipsychotics, then the activity of the postsynaptic neuron decreases, and the manifestations, which are the positive symptoms, decrease because these manifestations require an activated postsynaptic cell. Next, we also have antipsychotics that bind to the dopamine 2 receptor. So these drugs are usually the atypical antipsychotics or the second generation antipsychotics. So when the dopamine 2 receptor is activated by the atypical antipsychotics, then what happens is a decrease in the release of dopamine. And therefore, by decreasing the release of dopamine, we reverse the pathophysiology of schizophrenia and psychosis, which is excessive dopamine in the synapse. Next, we have drugs that produce the opposite effect, which is an increase in the positive symptoms, and therefore presentations of hallucinations and delusions. These are our psychotropic stimulants. Usually they are illicit drugs such as methamphetamine, the mushrooms, the hallucinogenic mushrooms, and ketamine derivatives, which are forms of anesthesia that have hallucinogenic potential. So they act as inhibitors of the reuptake of dopamine, and thus increase the levels of dopamine in the synapse and produce hallucinations. So they are hallucinogenic agents. Okay. Lastly, let's go into the treatment of schizophrenia. We can usually utilize two agents, two classes, the typical antipsychotics and the atypical antipsychotics. So the typical antipsychotics block dopamine 1 receptors. And so they directly prevent the activation of the postsynaptic receptor of the postsynaptic cell, which leads to the positive symptoms. However, because dopamine 1 selective antagonists or the typical antipsychotics have a very rudimentary structure, okay, which means it is not very specific to the dopamine 1 receptor. It has actions also on histamine and acetylcholine receptors. Therefore, when you give these typical antipsychotics, you will have increased occurrence of symptoms associated with blockade of acetylcholine, which means anti-muscarinic properties, drying of the mouth, increase in heart rate, constipation. Okay, so those are mediated by muscarinic receptors. Typical antipsychotics or the first generation antipsychotics, which bind dopamine 1 receptors and antagonize these receptors, also affect histamine and acetylcholine. Again, because they are not fairly specific to the dopamine 1 receptors in the ventrotegmental area, the VTA, which is the region of the brain where high dopamine activity is associated with psychosis, they will also block dopamine receptors in the nigrostriatal area, which, as we have discussed in the treatment of Parkinsonism, by blocking dopamine there, they will produce symptoms of Parkinsonism. And these are in total what we call extrapyramidal symptoms. So extrapyramidal symptoms because they affect the extrapyramidal motor tract, which are accessory motor tracts involving the basal nuclei and the cerebellum. So please be familiar with this table. Common first-generation antipsychotics are haloperidol, chlorpromazine, thioridazine, and thiofixine. Haloperidol is a butyrylphenone. Chlorpromazine is a phenolthiazine. So, chlorpromazine is the prototypical antipsychotic, which means it was the first agent discovered and to which all the other antipsychotics are compared to. So when you read your book, you will find out that the antipsychotic efficacy of medications are described as chlorpromazine units. For example, when we say aripiprazole has antipsychotic efficacy of 7 chlorpromazine units, this means that it is potent 7 times over than chlorpromazine. Okay, so that is the function of chlorpromazine. It is the prototype to which other antipsychotics are described. Haloperidol is very important in the acute management of patients in acute psychosis. So, what does this mean? When the patient goes into the emergency room and manifests frank delusions, frank hallucinations, disorganized thought and speech, and disorganized behavior, we can give intramuscular injection of haloperidol to sedate the patient, number one, and to treat the positive symptoms of psychosis. Aside from its use in the treatment of schizophrenia, haloperidol also has its use in the treatment of psychosis in the ICU. So, patients who have severe illness, they usually have dysfunction of the brain. And this form of brain disorder due to the acute medical illness can manifest as psychosis. So that is what we call ICU psychosis. So we also use haloperidol in these patients. The same thing, intramuscular injection. So the neurologic side effects of the typical antipsychotics more commonly, again, because they have very avid blockade of dopamine 1 receptors, but these are non-selective. That's why we experience a lot of these extra pyramidal side effects. These include acute dystonia, which means that the face, the neck, and the back muscles are very spastic, no? And they are contracting inappropriately, and that makes them harder to move. Okay, so dystonia here is a form of hypokinesia, which means movement is impaired. Movement is less likely to occur because of the spasm of the muscles of the face, the neck, and the back. So this is a neurologic side effect of giving the typical antipsychotics. Another extrapyramidal symptom is akathisia, which means motor and psychologic restlessness. Again, because dopamine 1 receptors in the nigrostriatum is also inhibited, then this will result in Parkinsonism, which will manifest as rigidity, bradykinesia or slow movement, postural instability, and the like. Okay. Another extrapyramidal symptom is tardive dyskinesia, which means that there is this time hyperkinetic, no? Ibig sabihin, there is excessive movement which is out of control, usually of the face. So that's tardive dyskinesia. Okay. And lastly, this is not an EPS, but is a very important side effect of these antipsychotic medications. You have neuroleptic malignant syndrome. So when you see the word neuroleptic, that means antipsychotic. Okay? So neuroleptic malignant syndrome is an idiosyncratic reaction. So if you recall, um, your ADRs, adverse drug reactions. Idiosyncratic means there is a highly genetic basis to the adverse effect, and this affects some persons in the population over the others because of their genetic predisposition. So neuroleptic malignant syndrome is an idiosyncratic reaction to the antipsychotic given, and this will manifest as tetanic contractions without resting. No? So there's contractions all over the muscles of the body, and there is no rest period, unlike in seizures where there is a rest period. Because there is no rest period, the muscles get damaged, and this is what we call rhabdomyolysis. And so the myoglobin in these muscles are spewed into the blood and they damage the kidneys. There is also fever and cardiotoxicity in neuroleptic malignant syndrome. Okay, the atypical or the second generation antipsychotics. The pharmacodynamics, sorry for that. So, the special pharmacodynamic properties of second generation antipsychotics are less potent binding to dopamine 1 receptors compared to the typical antipsychotics. So they bind there less avidly, but they have significant effect on the auto-inhibitory dopamine 2 receptors, which indirectly decrease the release of dopamine into the synapse. The, the great efficacy of the atypical second-generation antipsychotics are attributed to blockade of serotonin receptors. So they also block dopamine 1 receptors, and they agonize dopamine 2 autoreceptors, leading to decreased dopamine release, but more importantly, in their action against psychosis is the blockade of serotonin receptors. And if there is one thing that you should remember, for second generation antipsychotics, they block serotonin receptors and dopamine receptors. Because there is less potent binding to dopamine 1 receptors, then the occurrence of extrapyramidal symptoms are rare. So here are the common second generation antipsychotics. Aripiprazole is a very potent antipsychotic, and it exists in an intramuscular depot form, which means that patients with psychosis can have very good control of their disorder with just one shot intramuscular of the aripiprazole per month. So they just go to the doctor, and the doctor administers the aripiprazole intramuscularly once a month. So they go to the doctor once a month. But aripiprazole also has an oral formulation. But together with all the other second generation antipsychotics, these oral drugs and the second generation antipsychotics in general have the propensity to cause metabolic syndrome, which is hyperglycemia and dyslipidemia, okay, and hypertension. So next, clozapine is the one of the earlier discovered second generation antipsychotic. Okay, what's special about clozapine is that it causes granulocytosis. A granulocytosis. So clozapine causes a granulocytosis, which means that the neutrophils decrease and the lymphocytes increase when you look at their complete blood count. So because of the decrease in neutrophils, these patients are at very high risk of infection. So as a clinical pharmacist, once you see clozapine, you should look at the complete blood count of the patient to look for low levels of neutrophils. Risperidone is the first discovered second generation antipsychotic, and it is derived from haloperidol, a butyrophenone. Quetiapine is somewhat the magic drug in the treatment of psychosis, because if you don't know the diagnosis, so the quirk with psychiatry is that you must first identify what the particular psychiatric illness is, and then you choose the best drug for it. And so, as I've said a while ago, there are many disorders that can lead to psychosis. But as a clinician, if they have a hard time um, finding out what subtype of psychosis it is, then they can give quetiapine, and usually that solves the problem, even if they don't have a very specific diagnosis. And quetiapine is also very special because it can be given for resistant psychosis, therapy-resistant psychosis. And lastly, quetiapine does not produce um, as as uh, as commonly the metabolic syndrome. Okay, so indeed it is a wonder drug for psychiatry, but it is very expensive also. And lastly, let's have some review questions. When do antidepressants take effect in general? 2 to 3 weeks. Okay, so please counsel your patients. If they are taking an antidepressant, they should expect at least 2 to 3 weeks before they see significant improvement. Okay, so they should not dismiss the lack of efficacy right there and then. Okay, it is not because it is not taking effect, but because it takes 2 to 3 weeks for the brain to calibrate its neurotransmitters. Okay, next, how do the mechanisms of action of first and second generation antidepressants differ? First generation, you have SSRIs. Okay, so they just increase serotonin in the synapse. And the second generation antidepressants have both activity on serotonin and norepinephrine increase in the synapse. And second generation antidepressants, although not very common, can produce a cure. Okay. Aside from blocking dopamine 2, second generation antipsychotics importantly block what other receptor? The serotonin receptor. And lastly, give common extrapyramidal symptoms. Number 1 would be dystonia. Number 2, Parkinsonism. Number 3, akathisia. And number 4, tardive dyskinesia. So with that, I hope you have a nice time learning about pharmacotherapy of 3 common psychiatric disorders.